Hey everyone. My apologies for having to cancel class today, but unfortunately my daughter was sick, so I wasn't able to make it into work. So I appreciate your flexibility with that. So in order to make up for what we missed today in class, I have prepared this voice lecture for you over the last section of Chapter 7, which was covering bipolar disorder. So let's go ahead and get into bipolar disorder. So precisely what is bipolar disorder? Well, the consideration of bipolar disorder includes two components. One is the depressive component, which we've already kind of talked about what depression kind of looks like. But in addition to that, it also includes mania. The mania piece of it really relates to irritable mood, elevated mood, characterized by symptoms that include like grandiosity, euphoria, and even increased energy. So picture these mania, bouts of mania as extreme bliss, euphoric, extreme levels of energy in which individuals experience for this. So the hypomania piece that's included in this, it can be good grief, can be included in this, are less severe forms of the mania. So it's not to the extreme degree or the extreme level, but it's still very similar to mania in regards to the same type of basic symptoms that the individual is experiencing, just not to such a significant level, okay? So with that, the bipolar it includes the mania as well as the depressive episodes, and you see those fluctuation in moods over periods of days, weeks, and definitely months. So the individual oftentimes is known to cycle and switches from one mood, one extreme, so mania, to the next where they're very depressed and lethargic. So what is some criteria that has to be considered when we're looking at a diagnosis for bipolar? Well, first, there has to be manic or hypomanic episodes. Okay, so that a person has to be experiencing those extreme swings of euphoria, extreme levels of energy, and it has to include some consideration of their level of functioning and the impairment in the functioning, okay? So with that elevated mood or extreme energy, there has to be 3 or 4 other symptoms included in that in conjunction with a depressive episode. So not only is this person experiencing those elevated levels of energy, but at some point then reverts to those depressive episodes, and they have to have 5 out of 9 depressive symptoms, okay? Now, with that said, there's 2 considerations and diagnoses of bipolar disorder, so bipolar 1 and bipolar 2. Now, what's the distinction? Bipolar 1 is where the person is experiencing those full manic episodes, lasting for at least a period of a week. Okay, so those extreme levels of energy, euphoria, those types of things. And in addition to that, they're also dropping down to those lower levels of depression. Okay, now for bipolar 1, a key component here is that the individual does not have to have experienced a previous depressive episode. Okay, the key factor here is that mania episodes lasting for about a week. All right, now in addition to that, bipolar 2 focuses on hypomania. Okay, so we talked about hypomania in the slide before. The individual is experiencing those similar symptoms of mania, however, it's not to the extreme degree. Okay, so less severe, happening at least for 4 days consecutively, and then also experiencing the depressive episode with that. Okay, so thinking about the level of functioning, bipolar 1 is more extreme mania, bipolar 2 less severe, less extreme. Okay. So when we look at these, bipolar 1 and bipolar 2, you can see here, let me back up here. Sorry. You can see on the switches between bipolar 1, how extreme those mania episodes are in the very top level with the red lines, okay? It surpasses the hypomania, and it's to the extreme degree. And then you see significant drops down for those depressive episodes that they experience, okay? As compared to bipolar 2, the depressive episodes are a deep dive, but the mania episodes are just, they're obviously less severe, okay? So showing the differences between bipolar 1 and bipolar 2. So when we think about bipolar and mania, what really does it look like? So for example, I want to pose these different things to y'all. It says, who doesn't want this? Inflated self-esteem or feelings of grandiosity, right? I would love to feel on top of the world all the time and maybe not have some burdensome requirements or concerns or maybe worries, different things like that. Decreased need for sleep. I would definitely go for this. It seems like I'm doing a lot of different things, as well as you all have a lot of things going on and requirements of you, and we all definitely don't get as much sleep as we probably need. But for some folks, especially experiencing mania, they can go days without actually sleeping. Someone maybe that's more of an introvert to be more talkative, right? To have numerous ideas and various thoughts kind of like spilling from you, for that matter. An increase in goal-directed activities, right? So why would you not want these things? I mean, it sounds like a great opportunity to be more productive as an individual and maybe come out of your shell somewhat. But could any of these be problematic? And most definitely, they certainly can. So when we think of the 4 F's, how can these different things be problematic to someone's functioning, the frequency in which someone experiences these different symptoms, the feelings of pain that could be associated with it, as well as can any of this lead to maybe fatal conditions for an individual. And when we think about it in the most extreme degree, yes, most certainly all of these different things can be very dysfunctional, can cause pain, and especially if the frequency is at a consistent, pervasive mode for individuals. And quite frankly, folks that have been diagnosed with bipolar do experience these symptoms and have tremendous challenges throughout their life. So looking at the 4 F's and considering the bipolar disorder. So frequency, like we talked about, mania has to be present, and an episode of mania has to be present for at least 1 week, hypomania 4 days, and the depressive symptoms have to last for at least a 2-week period. Okay, 2-week period. Now, we see this frequency, the prevalence in our population, it's about 1.8% people. In our population, and a male to female ratio, male just simply a little bit higher at a 1.1 to 1 male to female ratio. Right there, what we've seen historically, and the prevalence rates seem to be increasing. They're on an uptick for adolescents. And about 2.7% of the adolescent population will receive a diagnosis of bipolar, which is quite alarming, actually, as we see this particular percentage grow across that population. Okay, so looking at function, for individuals, the pursuit of goals that they have for themselves inadvertently become the main importance. And they start neglecting other duties that they have to attend to, because they become so hyper-focused and they pour energy into certain things, certain goals that they have. Then they start neglecting other pieces that are important to their daily functioning. which can cause tremendous challenge for folks. So, for example, say someone maybe has bipolar and they're addicted to drugs. The main sole purpose during those mania times is for them to stay awake and to find drugs and to be able to basically chase the next high. That can cause them to neglect a variety of other things, work, bills, taking care of family, taking care of themselves for that matter, those types of things. So you see that those factors can greatly impact them. The ideation of problems. So when folks are experiencing these mania episodes, and quite frankly, even depressive episodes, but the distractibility, the levels of distraction that they can experience because they have such an increased level of energy, that you see racing thoughts, maybe even sometimes hallucinations or delusions, thoughts of grandiosity, those types of things. So even as people pour themselves into their goals, what you can see is that they may achieve some goal or some level of the goal, but then that is often short-lived as they start to come off that mania episode and dive into that depressive episode that they experience. So as their mood shifts, that level of success can often decrease and can lead them and push them further into that depressive episode in which they experience. So make the depths of the sea even deeper for some individuals, because if you can imagine being so very creative and so very active and having flowing thoughts and ideas during those high intensity episodes, and then to drop down from there, you can imagine what that extreme would be for someone and the impacts that it has on their functioning. Feeling pain, so cycling between the two moods and the impacts really related to coming down off of that mania episode. So if for some reason, during that mania episode, they haven't been taking care of themselves, they've been not sleeping for periods, days on end, that can cause stress to their health, as well as emotional stress and pain related with that. Okay, the bipolar is one of the most deadly psychotic disorders, and folks with the bipolar disorder have an increased risk of suicide. There's a large percentage of folks that do attempt suicide and are successful with their attempts that are diagnosed with bipolar. So, something for you to think about. What is a mood disorder? When you think about moods, we think about just someone typically having different moods and expressing them. So feelings of sad, happiness, frustration, anger, those types of things. When we talk about a mood disorder, we're talking about those types of things and how the individual expresses themselves and moves through, how successfully they move through those types of disorders. So hence why we're talking about these. We've talked about bipolar and bipolar 1 and bipolar 2. We haven't specifically talked about cyclothymia or unipolar depression. We have talked about dysthymia as well. So cyclothymia, the chronic cycling between hypomanic symptoms and depression over an extended period of time. So hypomanic, those symptoms of mania, but just not to a significant degree like a manic episode would be. So you see the cycling between that and depression. And we're looking at a longer period of time, so at least for a year or two period, 1 year specifically in children if you're looking at that particular age group. Okay, so to a different level, most certainly, but this is a chronic pattern of the cycling between hypomania and depressive episodes. Okay, the unipolar depression is simply what it says. It is the depressive pattern without mania. Okay, so you might be saying, well, what's the difference between that and major depressive disorder? It's a single or reoccurrent episodes. Okay, so it's not just a continuous state of depression, but you have different episodes of depressive states that occur with no mania. Okay, no manic episodes. So how do we help folks, particularly with bipolar disorders? So the first and foremost, biological treatments and medication is really considered the first line of treatment for these folks with bipolar that have that diagnosis. Now, the unique thing about this is one of the go-to medicines that is used, which is lithium. Quite frankly, we're not quite sure what exactly works, why lithium works. It's definitely been used and shows effective interventions for helping those folks struggling with bipolar, and it specifically seems to help improve those manic episodes. So again, not necessarily sure why it works at this point in time, but we do know that it works for those folks. So often used and prescribed to folks with bipolar. Other medications, as you can see, anticonvulsants, those obviously used to treat seizures. Now, they do work, but their effectiveness is not as consistent, so it varies from individual to individual. And what they've seen is that one of the main things that the anticonvulsants help decrease that mania in the moderation of sodium channels, so reducing that sodium influx into the neurons and that processes. So the atypical antipsychotics have also been helpful. Originally, these particular medications were used to treat symptoms of schizophrenia, but they've also been shown effective in the treatment of bipolar. So also things that are certainly used. So those atypical antipsychotics include those benzodiazepines, the gabapentin, those types of things. In addition, ECT or electroconvulsive therapy has also been used. And while it has been shown effective, there's a lot of controversy surrounding that for the reasons that we've already talked about. So early on, we talked about ECT and that essentially it's causing the brain to seizure. So the long-term medical impacts that can have, does that outweigh the short-term periods in which people with bipolar experience those positive short-term impacts from ECT? So obviously some opportunities there of different methods to try, but mainly that medication is the go-to treatment for folks with bipolar. So psychological theories and treatments to help folks with bipolar. When we look at different psychological treatments beyond the biological, obviously, treatments, so what type of therapeutic approaches can be used? For folks with bipolar, psychoeducation shows a strong connection and effective approach for mania. With this psychoeducation, individuals with bipolar will work with a psychologist that involves having the patient understand themselves, understand the symptoms in which they are experiencing in order to help them better understand those periods of manic episodes and to alleviate any maybe doubt or ability to control or help manage those particular symptoms or episodes, I should say. With depression, it shows a modest outcome for that. Systematic care. So systematic care is a form of treatment which involves a creation of a specific treatment plan or a routine in which patients have. So there's ongoing access, frequent care for these folks. And that has shown to be a very good outcome or effective for those manic episodes. And then cognitive therapy, modest effectiveness for both mania and depressive episodes for folks. So cognitive therapy, tapping into those cognitive thought processes and thinking patterns of those individuals seems to kind of help, but there are other alternatives that are more successful and effective, specifically treating those manic episodes. So a very challenging group of individuals to work with because of the particular symptoms in which they experience and express. So you may or may not know some of these folks that I've listed up here on the slides. So some celebrities with depression on the left-hand side and folks with bipolar disorder on the right-hand side. So you may, like I said, you may or may not know, but these folks have, talked about and openly expressed and shared their diagnoses with the public. So that wraps up our bipolar discussion. So hopefully you all understand the difference between bipolar and depression. For your upcoming exam, it will be important to be able to distinguish symptoms, understand appropriate treatments, and the connection of theories and psychological approaches to help folks with depression and folks diagnosed with bipolar disorder. Important to remember that bipolar disorder is different from depression. However, they are both considered mood disorders collectively. Bipolar includes those manic episodes versus depression, where you see that consistent pattern of depressed symptoms and moods. Okay, so please make sure that you know those differences for your next exam. All right, that's all I have for you folks. I will look forward to seeing you all on Tuesday, and have a great weekend.